in medicine, TTP stands for Thrombotic Thrombocytopenic Purpura. It is a rare and potentially life-threatening hematological disorder characterized by the formation of blood clots in small blood vessels throughout the body, leading to low platelet count, aka thrombocytopenia, microangiopathic hemolytic anemia, organ damage, fever, and neurologic symptoms. Despite receiving appropriate therapeutic management, thrombotic thrombocytopenic purpura remains a serious condition with a mortality rate ranging from 10% to 20%. This video aims to explore the clinical presentation, underlying mechanisms, diagnosis, and treatment approaches for thrombotic thrombocytopenic purpura. TTP is primarily caused by a reduction in activity, either acquired or genetic, in the von Willebrand factor, VWF, cleaving metalloprotease enzyme called ADAMTS13, which plays a vital role in regulating the size of von Willebrand factor multimers. Acquired aka non-inherited TTP, distinguished by the presence of autoantibodies targeting ADAMTS13, is more prevalent compared to genetic, aka inherited TTP, which arises from a deficiency in the TTP gene. The exact trigger for the development of autoantibodies in acquired TTP is not fully understood. However, it is thought to involve a combination of immune dysregulation, genetic predisposition, and environmental factors. Genetic, aka inherited TTP is due to a germline mutation of the ADAMTS13 gene. Inherited TTP is not due to the presence of autoantibodies. ADAMTS13 stands for a disintegrin and metalloprotease with thrombospondin motifs 13. This enzyme plays a crucial role in cleaving von Willebrand factor multimers, which are involved in platelet activation and aggregation. Von Willebrand factor is a large glycoprotein involved in blood clotting. It forms multimers of varying sizes, with larger multimers being more prone to causing excessive clotting. Von Willebrand factor is primarily stored in specialized cells called endothelial cells and platelets. Endothelial cells line the inner surface of blood vessels throughout the body. They synthesize and store VWF in specialized storage organelles called Weibel palate bodies. These Weibel palate bodies contain high concentrations of VWF, among other proteins. When there is a need for VWF, such as in response to injury or certain physiological triggers, the Weibel palate bodies release the stored VWF into the bloodstream. Weibel palate bodies are most commonly observed in endothelial cells lining small blood vessels and the intima of the heart. Platelets, also known as thrombocytes, are small cellular fragments involved in blood clotting. They circulate in the bloodstream and also contain stored VWF within their alpha granules. When platelets are activated during the clotting process, they release VWF from their granules to help with platelet adhesion and aggregation at the site of injury. In TTP, the absence, dysfunction, or inhibition of ADAMTS13 leads to an accumulation of large VWF multimers in the circulation, promoting platelet activation and aggregation. Thrombotic thrombocytopenic purpura occurs at a higher incidence in females age 10-50, and it is characterized by a tendency to relapse. The clinical features of TTP can vary, but common symptoms include a pentaad of the following. 1. Thrombocytopenia, low platelet count, which can lead to bleeding manifestations like bruising, purpura, hedache, which are small red or purple spots on the skin, or mucosal bleeding, example nosebleeds, bleeding gums. 2. Microangiopathic hemolytic anemia. The blood clots within the blood vessels can damage red blood cells, leading to their destruction. I.E.Hemolysis. These microthrombi can cause mechanical damage to RBCs as they pass through the narrowed vessels, resulting in a phenomenon known as microangiopathic hemolytic anemia. This can result in anemia, characterized by fatigue, pale skin, and shortness of breath. 3. Renal dysfunction. The formation of blood clots in small blood vessels can impair blood flow to various organs, leading to organ damage. A commonly affected organ includes the kidneys, resulting in kidney failure. 4. Fever. 5. Neurological symptoms. Neurological symptoms in TTP may include headache, altered mental status, seizures, visual disturbances, speech abnormalities, motor deficits, and altered consciousness. A mnemonic to remember: the PENTAD is the acronym FATRN. Prompt diagnosis and treatment are crucial in TTP, as it is a life-threatening condition. Presentation. To ensure thorough understanding, let's review the presentation of thrombotic thrombocytopenic purpura, TTP, once more. Thrombotic thrombocytopenic purpura, TTP, is characterized by a cluster of symptoms known as a PENTAD. Notably, this PENTAD includes a triad of symptoms, namely 1. Thrombocytopenia, aka decreased platelet count, which leads to increased susceptibility to bleeding. 2. Microangiopathic hemolytic anemia, characterized by decreased hemoglobin, the presence of schistocytes or fragmented red blood cells, as well as increased LDH levels. And 3. Acute kidney injury, which is indicated by elevated levels of creatinine. In addition to the triad, the PENTAD also encompasses fever and neurological symptoms. It is important to note that both TTP and HUS share the same triad of symptoms. However, HUS is further characterized by the presence of bloody diarrhea and is typically observed in children. Diagnosis. ADAM-TS13 serum activity and autoantibody testing can be utilized as ADAM-TS13 serum activity is expected to be lower than normal. Autoantibodies are expected to be increased in acquired TTP as they are what inhibit ADAM-TS13. Prothrombin time, PT, and partial thromboplastin time, PTT, values are normal in TTP because the coagulation pathway is unaffected. Normal prothrombin time and partial thromboplastin time values aid in differentiating between thrombotic thrombocytopenic purpura, TP, and hemolytic uremic syndrome, HUS, where the coagulation pathway remains unactivated, from disseminated intravascular coagulation, DIC, where the coagulation pathway is activated. To delve deeper into topics like hemolytic uremic syndrome, disseminated intravascular coagulation, and other coagulation-related subjects, I suggest checking out the separate videos on this YouTube channel dedicated to each of these topics. Complete blood count, CBC, can be used to aid in diagnosis. The CBC in TTP typically reveals the following. Thrombocytopenia. TTP is associated with significantly low platelet counts. Normal platelet counts range between 150,000 and 450,000 platelets per microliter of blood. In TTP, platelet counts may be markedly reduced, often falling below 20,000 platelets per microliter. 20,000 platelets per microliter is enough to cause spontaneous bleeding. Low platelet levels explains the history and physical exam findings of purpura, petechiae, hemorrhagic bleeding, gingival bleeding, epistaxis, and other bleeding problems. Hemolytic anemia. TTP is also associated with the destruction of red blood cells, hemolysis, leading to anemia. Anemia is characterized by a decrease in the number of red blood cells and a decrease in hemoglobin levels. The destruction of RBCs in TTP leads to the release of hemoglobin into the bloodstream. The released hemoglobin is subsequently processed and cleared by various mechanisms in the body. As a result, the overall concentration of circulating hemoglobin decreases, leading to a decrease in hemoglobin levels observed in laboratory tests. Hemoglobin levels may be decreased, but additional red blood cell parameters such as mean corpuscular volume, MCV, and mean corpuscular hemoglobin concentration, MCHC, may be within the normal range despite the presence of hemolytic anemia. This is because TTP primarily affects the fragmentation and destruction of red blood cells, RBCs, rather than altering their size or hemoglobin concentration. While the presence of fragmented RBCs and microangiopathic hemolytic anemia is a characteristic feature of TTP, it does not necessarily affect the overall size, MCV, or hemoglobin concentration, MCHC, of the remaining intact RBCs. Blood smear examination. A peripheral blood smear is examined under a microscope to evaluate the morphology of red blood cells. Presence of fragmented red blood cells, schistocytes, may be indicative of microangiopathic hemolytic anemia, suggesting the possibility of TTP. Tests to help evaluate organ involvement and detect signs of microangiopathic hemolytic anemia can be used. Treatment. The treatment of TTP involves plasma exchange therapy, which is considered the primary treatment modality and has contributed to excellent survival rates. Treatment of TTP via plasma exchange or plasma infusion replaces the deficient ADAMTS13 enzyme and removes the large VWF multimers from the circulation. Plasma exchange involves removing the patient's plasma and replacing it with fresh frozen plasma or other blood products, aiming to remove the large VWF multimers and replenish ADAMTS13 levels. Other medications, such as corticosteroids, such as glucocorticoids, and immunosuppressive drugs, such as rituximab, may also be used to suppress the immune response and prevent further clot formation. In refractory cases, splenectomy may be considered. Despite appropriate therapeutic management, TTP remains a life-threatening condition with a mortality rate ranging from 10% to 20%. Prompt diagnosis and initiation of treatment are essential to improve patient outcomes and reduce the risk of complications associated with TTP. Ongoing research efforts continue to enhance our understanding of the underlying mechanisms and identify new treatment strategies for this challenging hematological disorder. In summary, thrombotic thrombocytopenic purpura is typically caused by a deficiency in the enzyme ADAMTS13, which is responsible for breaking down a specific protein called von Willebrand factor, VWF. When ADAMTS13 is deficient, VWF is not properly regulated, leading to the formation of abnormally large VWF multimers. These large multimers cause the platelets to clump together, forming small blood clots in the small blood vessels and consumptive thrombocytopenia. The adherence of VWF to the endothelial cells can cause direct injury to the endothelium, triggering an inflammatory response. This endothelial injury and inflammation further contribute to the formation of more platelet-rich thrombi. The microthrombi can obstruct the small blood vessels, impair blood flow, and cause tissue damage in various organs. Additionally, the presence of platelet-rich thrombi within the microvasculature can lead to shearing forces, causing red blood cells to fragment and result in microangiopathic hemolytic anemia. The combination of endothelial injury, platelet aggregation, and microvascular thrombosis contributes to the clinical manifestations seen in TTP, such as thrombocytopenia, microangiopathic hemolytic anemia, and multi-organ dysfunction. We will break down each word in TTP right after giving a thanks to our sponsor. We would like to express our gratitude to our sponsor, First Cup Coffee, the original seed, for making this video possible. Shop firstcupcoffeeusa.com. First Cup Coffee, the original seed, is dedicated to providing high-quality coffee that fuels your studies and work with a rich and invigorating taste. We appreciate their support in bringing you valuable, free educational content. Remember to visit firstcupcoffeeusa.com for your daily dose of exceptional coffee. Now, let's break down each word in TTP. Thrombotic. The term thrombotic refers to the formation of blood clots, thrombi, within the blood vessels. In thrombotic thrombocytopenic purpura, TTP, the presence of widespread microvascular thrombi is a characteristic feature of the disease. Thrombocytopenic indicates a low platelet count. Platelets are crucial for blood clotting, and the decrease in their numbers can lead to a tendency for bleeding. In TTP, there is a marked reduction in platelet count due to platelet consumption and the formation of platelet clumps within the microvasculature. Purpura refers to the presence of purple or red discoloration of the skin caused by bleeding into the skin. It is a result of the microvascular thrombosis and subsequent damage to small blood vessels in TTP. Thank you for watching, and be sure to talk to your healthcare provider if you have any questions or concerns about your medications and any health conditions you may have. Disclaimer: The information presented in this video is for educational and informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard or seen in this video. That's a wrap for today's lesson on TTP. I hope you found this video informative and helpful. If you have any questions or topics you'd like us to cover, let us know in the comments below. Don't forget to like and subscribe to our channel for more educational content. Take care, stay healthy, and I'll catch you in the next video. Bye.